I've just completed what is 100% total capsulectomy, 10/8/24. As you will see, this is a grade 3 capsular contracture she had on the right side. I cut out the scar. As you can see, it's a very prominent scar all the way from here to here. And so I just removed the whole scar because I wanted to revise it. And then on the right side, you will see inflamed tissue that I found that was abnormal thick that I removed. These are your tear sharp drape implants. Nice lady from Bangkok, comes in all the way from the Orient. So this is the right side. She had 2 sets of surgeries in 08 below the muscle. In 08, earlier on in the year, she had 1 set, then that malpositioned, so she ended up going to a different surgeon and ended up getting basically another set put in later in the year. So as I go in, as you can see, the capsule is very tightly adherent to the implant, and so all of this tissue, I'm going to go ahead and see where I can go in. Let me go in from here. And as I go in, you can see the one thing I want to highlight is this tissue that I'm removing. As you can see, is scar tissue, maybe from the first set of implants, second, and so it is incomplete because technically this is the inflamed tissue around this capsule. The capsule is here. This is the inflamed tissue. This needs to go as much as the capsule itself. And I just want to show this is very tightly adherent to that implant underneath. So this tissue is all bad. As you can see, I've removed it because it feels bad, it looks bad, it palpates bad, it's abnormal, it's inflamed. Surgery, she had a relatively large implant for her chest width. So I'm going to go in very slowly here. Here we go. Textured implant, the moment I go in. Textured implant, tightly adherent. So again, I have the tip of the scissors are blunt, as you can see. When I go in and I just open. And the best way to remove this, as you will see shortly, go like this, turn around, and you can hear the sound how it. So again, going in, you go like this, dissect, and then you open up, and you can actually hear it. That's how tightly it is adherent. Again, as you will see. Now the ultimate best way is to put your finger in and just bluntly dissect, and you'll hear it. You can see how thin this capsule is. You can actually see my blue glove. I'm going to cut this open right here. So textured implant. So as I'm going to go ahead and tear this. Some fluid. Look at this fluid that's around. So none of this fluid has leaked into the chest. It's just inflammation fluid, not enough to send to cytology. Remember, if there was some more, then I would have sent that off. So as you will see as I dissect, you can actually hear it. Look at this amount of fluid. So what I'm going to do is, please remain exactly where you are. Flimo, can you pass me that syringe? So I just want to show and see if there's any more fluid that's going on. So look at this fluid. Very interesting. I'm going to go ahead and so remember, not any fluid around the implant, all contained. And I'm going to send this up to cytology. I was not expecting this. You don't want to leave this behind. And you can see there's some debris. So this is I would say a good sized amount of fluid. Now I'm going to go ahead and put this down here. None of this fell out into the chest. I'm going to go ahead and get some more. There's a fluid collection, as you can see right here. Remember, the pathologist is going to weigh in. Look at this. This is like edematous, like very swollen. You see? Let me get some more. I'm going to collect as much as I can. So I'm sucking this out. So here you go. So as you can see, it's turned a little bit yellow. You can see this consistency. I can actually tear this amount off. It's like gel, like jello, if you will. And so it's thicker here. So complete removal. If I take the ruler, if I put my, you can actually see 5, you can read right through it. No matter what, how thin it is, that fluid cannot fall into and leak into. And I'm very happy and content with how this whole surgery went. Now, I'm going to go ahead and put this here. I just want to show one other thing. If I take this, so there's fluid that's around. It's within. And so this is, we have seen many times with the textured implants. Remember, textured implants are notorious for association with the BIALCL. Remember, the BIALCL is very rare of rare, but the textured implants have been implicated more in their association with BIALCL than smooth implants, even though smooth implants are also associated, but to a much lesser extent. So this is she actually had her surgery done in England, and these are 2,000. This is your 280 grams, 280 grams, and this is your McGann implant. So 280 grams McGann, tear sharp draped, and you can see how this implant is sitting. So the take-home message is any fluid, and you can see, look at the debris matter inside. I sucked some of this gel consistency as well, and they're going to do a cytology analysis. And for the record, I am going to mention that this is your 4 cc's that I've removed, and I'm going to send this off to cytology separately. Take home message: any fluid around the implant, there's a big red flag for what is the BIALCL. CD30 analysis must be done. Rule out the lymphoma. It is, I use the word malpractice to not send this off, because you have to quantify, you have to send this off, and you have to do the workup. Even, especially when it's textured implants, even if it was smooth saline or smooth silicone implants, you have to send the fluid off to cytology. Now on the left side, I changed my top glove. Again, I removed that scar tissue, and I'm overall very happy with how the whole dissection has gone. And I'm going to go in here. So it was literally super glued to the chest, much wider and bigger than the chest width, if you will. So what I'm going to do here is we're going to go in. You can see the scissor is like literally jumping. That's how thick that tissue is here. Sometimes it's easier to go in from this thicker side. Here we go. But this is all that inflamed tissue. Remember, if I leave this tissue behind, right, this is part of the badness, if you will. So I'm going to go in from here. There's a secondary capsule here. You can see right here. It's very interesting. Remember, this is the capsule, secondary capsule. I'm going very slow. It is very tightly adherent to that textured nature. Remember, that is one of the indications, because she had this malposition. The surgeon put in the texture so it will literally super glue. I'm actually going to go in from here. Let's try another area. If you see, I actually cut into this implant. So my bad. You can see I cut into it. It's super tightly adherent. I'm going to go in from here. I can see this is my cut right here. And you can see it's literally super glued. I'm going to find another area to go in. There we go. All right. I'm going to go ahead and grab this. I'm going to just use my finger now. You're gonna hear it. Again, you're gonna hear it. You can see how hard it is calcified. I love it. Let me go slow. So you can see how it's super tight it is, like super glued. This is the secondary capsule. So usually around this clear area where you have the label, you're going to find it's going to be not stuck. So very small amount of fluid. This is not enough to send to cytology, unlike the right side. So this is a secondary capsule. You can see this is the clear part, and you can see this is the imprint of that clear. So this is, I'm going to go ahead and dry this out. This is your 280 McGann as well. And as you will see, this is the fluid that forms around, not enough to send. And you can see the capsular tissue. You can see the imprint. Literally, you can see the writing on the back of it. That's how clear it is. And so overall, I'm very happy. You can see my blue glove, how thin the capsule is. So the take-home message, number one, if there is any fluid around the implants, be it smooth saline, be it smooth silicone, or be it textured implant, that fluid has to be sent to cytology to rule out the BILCL. It must be done. Remember, this is a very rare cancer, and the surgeon has to send it to pathology and direct the pathologist to do a CD30 analysis, because if that CD30 analysis is not done, the pathologist will not be considering or factoring in the differential. The capsule must be entirely removed in the en bloc fashion, as you can see on the right side. None of that fluid spilled into the chest. As you can imagine, if you spilled this debris content into, there is no kind of bringing it back. It's going to spill. I have removed a bacterial contamination, as you have seen in the past. In this case, fluid. You have to rule out malignancy to be complete. The capsules will be sent to pathology, rule out the BIL, CL, CD30 analysis, rule out SCC, squamous cell cancer, breast cancer, anything abnormal. We'll see what the cultures show for aerobic, anaerobic, and fungal. And I'll return both of these implants back to the patient. As you will see on the left side, as I was dissecting, I made this cut on the side. It's very subtle, but it's there. And this is, what's interesting is, this is that gummy bear type of the implant, if you will. There you go. So if you can see, it's a gummy bear type of an implant. This is my cut. I made this happen. But as you have seen, these same implants, years later, will eventually disintegrate just like the implants in the 80s and will become molten, if you will, and they will melt away. So there you have it. One has to always go into the surgery assuming they're ruptured or that there's fluid around. You cannot be fast forwarding the surgery and be done with the surgery in 3 hours along with the lift, because that is just way too fast. There's a certain etiquette and a certain technique that needs to be done, which is care, precision, and very meticulous surgery, such that none of this fluid spills into the chest and that all of that capsular tissue is removed. As you can see, the other take-home message is that soft tissue around that capsule must be removed sincerely, completely, definitively, so that there is no inflammatory burden left behind that may ultimately end up hurting the patient. So there you have it. This is Dr. Khan, Executive Plastic Surgery.